Hi everyone, it's my pleasure to be with you here today. I'm Dr. Amr Soliman from Kiwi School of Medicine in New York, and I'm going to talk to you today about the Cancer Epidemiology Education in Special Populations program that I direct. We call this program CEESP. This program is for training public health students on cancer epidemiology and different aspects of public health. The name of the program is epidemiology, but the program is not for epidemiology students only. It's open to all students from all concentrations and departments of public health. So the program provides funding for the students to conduct research. Okay. So to conduct research in global settings and minority populations in the US. I'm going to talk about the global part today. Why do we do global cancer research, and why are we interested in having students do global cancer research? Because cancer is not one disease. Even if we are talking about the same cancer site, talk about colon cancer, it's not the same cancer in different populations. So the rates are different. How people develop cancer, the pathways of cancer are different. The etiology of what causes cancer in different populations is different. The clinical presentation of cancer is different in different populations. When we think about translating our research into prevention and control, we need to understand cancer in different populations. That's why we need to do research in different populations. Also, what you learn in classrooms, you cannot apply as you learn from the classroom classes of epidemiology and public health to work in special populations or global settings. So that's why we are interested in motivating students to pursue careers in cancer research in global settings. We also have the interest in conducting research globally because what we learn globally from cancer research is applicable to the US. So we are benefiting the US population from conducting research in different countries. The advantage of different countries is that they have high and variable levels of environmental exposures, higher level of infections than the US, variability of lifestyle factors, and all these factors are important for conducting cancer research and finding observations and results from epidemiologic and public health research on cancer. As I mentioned, you cannot just take the textbook epidemiology methods and apply it to foreign countries. That's why there are new methods that you learn from doing field epidemiology in different countries. The other issue is that we spend much less money when we do global studies. For students, this is also important from learning and education and career opportunities. So you learn how to develop research questions in untraditional settings. You learn how to deal with populations with different cultures and backgrounds. You learn how to package the results from your research for scientific writing, publications, and how to improve your CV. And also you learn how to seek jobs. If you do that sort of challenging research from low and middle income countries, you are more appealing to employers in the US because you did the difficult stuff. Then you can survive in any type of jobs in the US. And also this special population and global research opens so many opportunities to students, as I'm going to show you later in this presentation. So what we do is we do the classic epidemiology research, get data on incidence, mortality, stage of cancer, clusters of cancer. We get this information and translate it into epidemiologic and etiologic research to understand gene-environment interaction, social determinants of cancer etiology, and also understand risk factors of cancer. As I mentioned, we translate epidemiology to prevention, early detection, screening, special treatment to special groups of patients. And when we have advanced cancer, we also tailor palliative care to patients who are diagnosed at advanced cancer stages in different low and middle income countries. If you look at this figure, the bottom part of the figure will show you the red as the incidence and blue as the mortality. The bottom part of the figure is showing that incidence is almost equal to mortality, and that's low-income countries in sub-Saharan Africa. In the United States and Western countries, the top part of the figure, we have much higher incidence of cancer in the United States and Western countries, but we have significantly lower mortality. Why? Because we discover cancer early, better chances of survival. We have screening programs, so we get all the cases that would have been diagnosed 5, 10 years later. So that's the difference between developed countries and developing countries. And all these distributions and differences in incidence and mortality are interesting research questions for students for conducting research in low and middle income countries. Cancer will be a major problem in developing countries in the future. We expect to see significant increase in cancer rates, incidence, and mortality in developing countries over the next 2 to 3 decades. Cancer is currently killing more people, more than the traditional infectious disease such as HIV/AIDS, TB, and malaria, but cancer is not noticed as a major health problem up till now. It's going to be more in the future because populations in developing countries will live longer. Cancer is a disease of older population. When you have aging of the population, you're going to have more cancer cases. In the United States, we reached a plateau. We catch all the cancer cases because of our screening program, and our life expectancy is not going to increase more than what we have now. Cancer is different from one population to another. This is showing Africa as an example. If you look at the right side map, this is the cancer map of women in Africa, and there are differences in the African continent. The top part is North Africa. Breast cancer is the most common cancer in North Africa. Sub-Saharan Africa, you see cervical cancer as the most common cancer. So different exposures, different risk factors, and that's why the cancer patterns are different. If you look at males, and in the map here, you see North Africa with specific cancers related to lifestyle, tobacco smoking. People smoke very high rates of smoking in North Africa. That's why you see lung cancer and bladder cancer, and both cancers are related to tobacco smoking. Tobacco smoking in sub-Saharan Africa is very low. So you don't see these cancers in sub-Saharan Africa, but you see other types of cancers. You see prostate cancer because of genetic susceptibility of African men to prostate cancer. You see infections. So you see liver cancer and HIV-related malignancies. These are very interesting questions and research questions for students and for researchers. And I'm showing Africa as an example, but if I show you the world, you're going to find different cancer patterns in different populations because of different risk factors and different genetic susceptibility. These are two of the cancer centers that we have in Africa where we have strong infrastructure. The white building to the left is the Ocean Road Cancer Institute, the main cancer center in Tanzania. The right building is the Kamfanuchi Cancer Center in Ghana. We sent about 40 students to these cancer centers doing research over the past 17 years. We have many sites like these cancer centers in different countries, and the setting, the collaborators know what our students need, and they provide all the resources for the research of the students. I'm going to show you some of the examples of what we do in different countries. The pictures on the right side of the screen are for a special type of breast cancer called inflammatory breast cancer. Women present with inflamed like breast, as you see. The breast is red and the breast is distended or looks like an edema or engorgement of the breast. This is cancer. The pictures on the right is very common condition in women in developing countries and in the US called lactation mastitis. Lactation mastitis is when women breastfeed and they have infection of the breast, they're gonna have the picture that you see here. The treatment here is antibiotic. The treatment here is chemotherapy and removal of the breast. Why are we interested in inflammatory breast cancer? Because this is very aggressive and severe type of breast cancer. If you think about the majority of breast cancers in the United States and think about survival, if you have 100 women diagnosed with breast cancer, non-inflammatory, not the inflammatory, not IBC, the survival is at least 95 to 98%. So you'll have women who will live at least 5 years. You know of women who have breast cancer and they live 15 and 20 years, and that's the majority of breast cancer. And that's because we have better treatment in the US and we diagnose cancer early. But these types of IBC are very aggressive types of breast cancer. And even in the United States, the survival is about 30 to 40%. So women who are diagnosed with this type of breast cancer, even in the US, only 30 to 40% of them survive 5 years. Very aggressive, very lethal type of breast cancer. We study inflammatory breast cancer in North Africa because of the high frequency of the disease there. In the United States, this disease is about 1 to 2% of all breast cancers. There is a consortium and advocacy group for inflammatory breast cancer. You can find it on the web because this is very aggressive type of breast cancer. And it's very sad that only 40% of women survive for 5 years. So you'll find mothers who are part of this advocacy group because 60% of the patients of this rare type of breast cancer did not survive. We do research on this in North Africa, in Morocco, Tunisia, and Egypt. We have the largest study in the world on inflammatory breast cancer. We study everything from epidemiology and exposure and treatment of this disease. So this is an opportunity for students. The CEESP program is also having a component on infection and cancer. So we are not just studying epidemiology from exposure lifestyle. We are also interested in combining infection and cancer. And some of the students are not interested in cancer, but they can come to cancer from women's health interest, or infectious disease interest, or social epidemiology interest. So we have noticed in Africa that Kaposi sarcoma, a famous type related to HIV infection, has been declining steadily in Tanzania, but other cancers are increasing now and emerging among the HIV patients in Africa. So HIV patients live longer than before. We have treatment for HIV now, but the patients are not 100% with 100% immune response. So they still have immunocompromised stage. And this was a publication of one of our previous CEESP students, showed the cancers that are increasing in Africa after the treatment of HIV. So anal cancer, rectal cancer, cancer of the eye, lymphomas and thyroid cancers, also lung cancer and liver cancer. These cancers are increasing in Africa among HIV patients after the control of HIV. Why? Because we think HIV patients, when they survive, they change their lifestyle. They smoke more, they drink more, they have infection. And all these behavioral risk factors increase their risk for cancer, uncommon cancers that were very rare. This is interesting because we see this also in the southeastern part of the United States among HIV patients. That's what I'm saying. What we learn from global settings, we can translate it to populations in the US. We also see that these cancers, anal cancer, vulvar cancer, vaginal cancer, increase among patients who have HPV infection and HIV infection. This is a great opportunity for prevention because if you vaccinate adolescent girls and boys and women against HPV, you can eliminate these cancers completely. Cancers that are related to infections in the United States constitute between 5% of all cancers. In developing countries, these cancers represent between 25 to 30% of cancers. This is a great opportunity for eliminating these cancers completely if you have vaccination programs and introduce the vaccination of HPV. I mentioned in the beginning of my presentation that we need to tailor prevention according to our epidemiologic research. So this is specific, the prevention paradigm is specific to the population. We cannot take this and export it to other countries. We need to study each country or region to be able to develop this for each population. For example, who is at average risk for cancer? People like you, young people who are not at high risk for cancer. So the prevention here is lifestyle modification. Have healthy diet, work out, have physical activity, don't get much weight. The moderate risk are people like me with aging. We must go into colonoscopy and early detection of breast cancer and early detection of colon cancer. We set the limit in the United States, for example, for moderate risk for screening by age 50. So we say when you reach age 50, you must go for colon cancer screening. The United States noticed that we see more younger onset colon cancer now. So the age was lowered to 45. So the age of starting colon cancer screening in the United States is now 45. We have seen this young onset colon cancer in other countries long time ago, but now it's coming to the US. So this is how we learn from global settings to translate to the US. Of course, when people have very strong family history or hereditary cancers, it's another story of prevention. So this global work is challenging, but it's good also because it opens opportunities for students. We need to develop multidisciplinary teams for students to conduct research. We need to identify the best population for students to do research. Students learn a lot about cultural and logistical issues of how to deal with these populations. We have so many students who went to Africa. They learned barriers to screening in Africa. Now they translate this to migrant populations from African origin because they learn how to deal with cultural issues from Africa. Definitely this program is helping. I'm going to show you how this program is helping with career planning and capacity building of students, and also this an opportunity for discoveries and identifying causes of cancer. So the CEESP program is a program funded by the NCI, the National Institutes of Health, to develop capacity of students to continue careers in cancer. I'm going to show you this. And we've been doing this program for 17 years. I started this program when I was on the faculty of University of Michigan in 2006. And it's a 5-year grant cycle, and we have been renewed now for 3 times after the original 5-year application. We are interested in first-year MPH students, but we would consider second year if we have a compelling case that the students will be productive. Doctoral students, PhD, Dr.PH students, as I mentioned, all fields of public health. Students with or without prior experience qualified to apply to the program. We are very much interested in having a diverse group of students in this program. This is the timeline of the program. Now from September to January, we do recruitment, students submit their applications, we connect the students with different field site mentors, we review the applications in February, we select the students. This is a very competitive program. So we select about 15% of the applicants, the top 15%. And then students complete any requirements for IRB. Then the students go to the field. We pay for the students also to come to New York to have a 3-day career development workshop where they present their research and we advise them on future career planning in different settings. Starting next year, we're going to have a mentoring workshop where we're going to teach the students how to be good mentees, their rights and obligations, and we're going to teach the mentors also how to be better mentors. These are the sites that we have strong infrastructure. As I mentioned, we have most of our sites in Africa and the Middle East, but we expanded the program over the past 5 years. Now we have sites in Latin America, Asia, and Europe, and we are open to any idea or new setting if the student can provide evidence that he or she will be successful going to a new site. But we know that these existing sites will provide the best educational and research experience for the students. We have domestic sites in different populations. We are very much interested in opening sites here in Alabama, and the students can work with the local mentors here on ongoing projects of the faculty. This is part of what we teach in the post-summer career development workshop: how to search for jobs, how to prepare your CV, how to get your summer experience and add it to your CV. Students usually underestimate what they learned and they don't know how to package it on the CV. We help them with that. We talk about negotiating jobs, negotiating the scope of work, negotiating salaries, how to get jobs in different places. And we invite employers and mentors to talk to the students about jobs and future career steps. This is a cancer program, but I travel with the students, especially for the global part. We go to different primary healthcare clinics in different countries and hospitals because I want the students to learn public health, not just cancer. Learn about vaccination, maternal health, reproductive health, childhood vaccination and nutrition. So it's a full public health education program in addition to the cancer education. These are pictures of students in different countries. You imagine that the students will not get from anything from this picture of the unorganized medical records, but students get a lot of data and they publish. Our publication rate from this program is 78%. So 78% of the students publish at least one manuscript from their summer data, and students who finish the program publish 700 papers after they finish this program. These pictures are from the post-summer career development workshop. The picture here on the left is Dr. Stacy Fedwa, and she was a student in this program in 2006. Now she's the director of epidemiology at the American Cancer Society, and she comes to talk to the students about advantages in NGOs like the American Cancer Society. University professors from medical schools, public health, meeting with the students in groups and individually to advise the students. The top right picture here is Dr. Jackie Levine. She's the Director of Training and Education of the National Cancer Institute. She comes every year to talk to the students about jobs, training opportunities for students at the NIH and different institutes of the NIH. We bring the students each year to New York, additional money. This was the picture of our newsletter. We have periodic newsletters featuring the students and the mentors and success stories. And the newsletters are posted on our website. So this was the picture from the 2020 newsletter. That's where our students are. We have been doing this now for 17 years. So you find that our alumni who came, more than 90% of them came with no interest in cancer. And they became successful cancer researchers and working in different places. We have 30 alumni working as faculty or postdocs or scientists. We have 31 students who went from the MPH to PhD in cancer epidemiology. We have 23 students or alumni who are doing cancer coordination in cancer centers. And we have many students who are continuing in cancer-related fields. One of our first students, she was an MPH student in our program, and she finished our CEESP program and our MPH program in Michigan we introduced her to Dr. Walter Bohr, and at that time he had the R25 for PhD students. And she came here and finished her PhD in your department, Dr. Emily Volkman. Yeah. Now she is, I think she was here last year talking, and now she's a senior investigator at the National Cancer Institute. And this was one of our success stories. So Dr. Volkman, when she came to our program, she was not Dr. Volkman, she was Emily, and she had a great experience. And I remember I met with her 38 times until she developed her research project. At that time, we were doing just Africa and the Middle East. And she came to me and she said she wanted to do Mexico. I said, we don't do Mexico. She said, I'm going to convince you to send me to Mexico. And she said, convince me to go to Mexico. I'm sure you know her from being with you here for 4 or 5 years. And when she finished, she said she doesn't want to be the typical university professors. I don't think she told me that, but one of the other students told me. She was here on your faculty who told me that, Dr. Tomi Akimemutu. So Dr. Tomi, I was the doctoral chair of her doctoral committee in Michigan. And I said, Tomi, what do you want to do when you finish? She said, I don't want to be like you. I don't want to be a university professor. She became a university professor like me. Now she's an associate professor of epidemiology at Duke. But we have 2 of the success stories who came to your program here as doctoral students and faculty. So more than 90% of the students in this program came with no interest in cancer, and we converted them into cancer people. So this program, the application process is that there is a short application form. You send me an email, we schedule a meeting to talk about your interests, what we have. I encourage you to go to the website of the program. We record the videos of all the students from the beginning of the program. And each student, during her or his presentation, ends the presentation with ideas for future students. So students usually, about 50% of the slots are continuation from where previous students ended, and then the new student will continue. You develop a 1-page proposal and 15-slide PowerPoint presentation, and the same sections in the proposal and the PowerPoint presentation, reviewing the literature, identifying your specific aim, defining the methods of your research, and also what you're going to learn from this project and what's your future career plans. Students who are selected, they get $7,200 from this program. If they are doing global work, they can use the money for their travel, living expenses. And most students save money from the subsistence. If they are doing domestic work, they take this money as a stipend. And we also pay for the students to come to the post-summer career development workshop in New York. As I mentioned, I travel to mentor the students in the field. We pay for the students to go and present their work at different conferences. We have a student who will be presenting tomorrow at the American Public Health Association conference. She has an oral presentation from her work in Tanzania. And we continue to write letters of support and network and connect students with employers. This is my email address, and this is the website of the program. I'll stop here. I would be happy to take any questions.
When is the deadline for this year?
So the deadline is January 29th, but this will take back and forth communication. So Dr. Hoffman talked to me 38 times. If you talk to me 38 times, you need to start now, because it will take time to develop the project, connect you with the employers, and also make sure that you have an application that's going to be funded. So it takes time. I encourage all the students to start early, not to wait until January.
And then students who are accepted would then do their research or their travel in the summer of 2023?
Yes.
Okay.
Students usually travel after they finish their spring semester. And we have variabilities of travel dates because students finish at different dates. Some students travel in May, some students travel in April, based on where the school ends. we want students to use this experience for their school assignment. So we don't want to take the students out of their program, so they can use this for practicum, summer internship, whatever you call, because different universities have different names, culminating experience, different names. For doctoral students, they can use this to see if they like cancer, or they can use this to do part of their dissertation if they are doing a cancer dissertation.
Is there any mentorship for the application process?
Yes, talk to me, and depending on your project, your country of interest or population of interest, I will connect you with mentors to help you during the application process.
So there has to be like a project that the person is doing, or does the person?
No, you can come with no project in mind. You say, I'm interested in going to this population or this country, or I'm interested in social epidemiology, or I'm interested in women's health. So you don't have to come with a very preconceived ideas, because we're gonna help you to develop the idea. But the important point is to come with interest in domestic or global. It would be great if you come and say, I'm interested in domestic in Alabama, or I'm interested in global in Africa, because that will help you develop the project and will help us also to mentor you.
And do students need to have like experience with like quantitative data, like
No, students don't have to have prior experience in global or domestic settings. Students don't have to have data set. Students don't have to have anything. What we require is just having students who are in status. They are students in a public health program, and we recruit nationally. So that's why it's a competitive program, because we get students from different schools and programs. Citizenship is not required, so we fund also international students, and we want to help also local universities. So if you have faculty and you have an impressive cancer center here on campus, if you have students who want to work with existing faculty, campus faculty, cancer center faculty, we are fine with that. You're going to work with the local professor here on the ongoing project of the local faculty.
And one more question, like.
Sure, feel free to ask any questions.
So what differentiates, like what kind of candidates are then accepted in the program?
That is an excellent question. So, who is funded and how can you increase your odds of being selected? This is an excellent question. So we have a committee of 6 senior professors of public health. Dr. Waterboard was on our committee for many years. So the professors get the application and the PowerPoint presentation ahead of the interview date. We interview students for 3 full days. We meet from 9 o'clock to 6 p.m., 3 full days, interviewing each student 30 minutes, 15 minutes, the student will present the presentation and then discussion with the mentors. What the mentors are looking for is a small project that the students can start and finish during the summer. That's number one. So if the project is ambitious, very large, that's not going to be fun. That's number one. Number two, they want to see mentorship. So they want to see this student is connected with the off-campus mentor, and the local university is on board with this project. That's number two. Number three, they don't want to see a project with many issues, sensitive issues for IRP. This project is going to take 6 months to get approval for a sensitive project. And they want to see that this project is straightforward, so you can get the IRB approval from the local university very quickly. The other point, they want to see a learning experience for the student. So they want to see this student with a specific background continuing into a project that's going to provide the learning experience for the student. And they ask the student about her or his future career plan. So they want to see a story and a benefit for the student from participating in this program. So those are the students who are selected. And we analyze the data of our program to see how we predict success, because we provide money, we provide effort, we want to have the students successful, like Dr. Volkman and other students who were successful. So we found that students who are successful, and our definition of success in this program is students doing the full story from start to finish. So they developed a research question, they passed the interview successfully, they went to the off-campus location, they got the data, they analyzed the data, they wrote a manuscript. This is our definition of success. So we found that knowing the language of the foreign country is not a predictor of success, because some students don't speak the foreign language, but they know how to engage the collaborators in the research. So we found that the two most significant predictors of success are, number one, resourcefulness. The student who would not find this part for the study, but will be resourceful, doing search, contacting collaborators, finding mentors, doing stuff to get additional pieces to make this project successful. The other predictor was persistence. The student who will not take for no one. We have students who published a paper on this. 3 students in different countries, and the mentors said, oh, we don't have this data for you, or I don't have time for you today, or something like this. And they found ways to avoid stopping the project and being persistent. So I'm gonna call you tomorrow, I'm gonna call you on your cell phone, I'm gonna come to your private clinic. I'm gonna do anything to get this work done during the summer, because that is the main part of the project. I was talking to students this week, the George Washington School of Public Health students, and I had students from GW who passed the program successfully. And I was talking to one of them as a story for persistence. She went and she didn't find what she planned to do, but she was nonstop finding other ways to get the data and being persistent